our exit interview Counterpoint series. For those of you that are new to the series, the Institute of Politics and Public Service at the McCourt School of Public Policy launched this initiative at the beginning of the semester to really be the first oral history of the Obama administration. We focused on 6 different issue areas: national security, social and criminal justice, healthcare reform, climate change, the economy, and the political culture here in Washington. For each one, we were very fortunate to get a cabinet-level official from the Obama administration to come and have a conversation about how they saw the president's legacy in their issue area taking shape, what they think the greatest accomplishments were, and what they think some of the biggest challenges were, both for this administration and for the next. Half of the events were held before the election, several have taken place since. And as you can imagine, the tone was a little bit different before and after. True to our mission, though, we wanted to make sure this was a robust conversation in each issue area. And rather than just be an opportunity for the administration to make its case, we wanted to make sure that part of the conversation included a different perspective. And so we launched these companion Counterpoint events to get that different perspective. And I think in today's conversation, we're very, very fortunate enough to have one of the leading conservative, one of the leading Republican voices on the issue of healthcare reform, on the issue of the Affordable Care Act, here to join us today, and someone who is no stranger to this campus either. We want you to be very involved in the conversation using the hashtag #TheExitInterview. And we will still have a few more of the counterpoints to wrap up. We will be doing those right when we come back from winter break. But we hope you enjoy this conversation. The transcripts will all be bound from both the original event as well as each counterpoint to provide a journal. And we will be hosting the video of each of the events and counterpoint events on our website, again, to have an archive in this first oral history of the Obama administration. In order to introduce our moderator and guest, I'd like to invite up Joe Schartz, who's a first-year student in the McCourt School of Public Policy, who will give them the greeting that they deserve. Joe.
All right, thank you, Mo. In 2012, John Barrasso was re-elected to the United States Senate by a nearly unprecedented margin, capturing more than 75% of the vote to represent his home state, Wyoming. Senator, you're a popular man. He is the 4th ranking member among the Senate Republican leadership as chairman of the Senate Republican Policy Committee. And as RPC chairman, Barrasso helps develop legislative and floor strategy and provides his colleagues with in-depth analysis on policy issues. In addition to other committee assignments, Barrasso is a senior member of the Senate Energy Committee, where he's a steadfast advocate for American energy security and freedom. He is also known by many as Wyoming's doctor for his many years of providing public service announcements in TV, radio, and in newspapers. He has a long and recognized career in medicine. During his 24 years as an orthopedic surgeon in Casper, Wyoming, Barrasso served as president of the Wyoming Medical Society and was named Wyoming Physician of the Year. John has 3 children, Peter, Emma, and Hadley, and he and his wife Bobby live in Casper. Rachana Pradhan is a healthcare reporter for Politico Pro. Before coming to Politico, she spent more than 3 years at Inside Health Policy, focusing on the implementation of the Affordable Care Act. Prior to that, she worked at the Daily Progress in Charlottesville, Virginia, and spent most of her time covering city government, with the occasional foray into stories on urban chicken keeping and the closure of neighborhood pools. She's a rare local of the Washington, D.C. area and graduated from James Madison University. She was also a news editor of JMU's student newspaper, The Breeze. Please join me in giving a Georgetown welcome to our 2 very distinguished guests this afternoon.
Thank you, Senator, so much for participating in this very interesting and very timely discussion, of course, since we're going to be in for busy 3 months, if not years, it seems like, in January. So what I wanted to start with was you won re-election, of course, in 2012, but you've been in the Senate now for nearly a decade. The U.S. healthcare landscape is quite different now than it was when you first came to Washington. So could you bring us back, like, why don't you take us back to what was happening in 2008, and how and why did the ACA come about?
Well, thank you. Thanks so much for having me. It's wonderful to be here back on the campus of Georgetown. My son Peter is also a graduate of Georgetown University. Our daughter Hadley graduated from Loyola Marymount in LA, so she considers that the Georgetown of the West, the Jesuit institution. And you're 100% right that as I've been practicing medicine in Wyoming for 25 years, I've gone here undergraduate, here to medical school as well, and then done a 5-year residency, and then to Wyoming starting to practice in 1983. We know we needed healthcare reform in this country because the real problem was the cost of care. The cost continued to go up. People were concerned about what it was costing. So we needed to do something. And the president gave some wonderful aspirational speeches. One at the American Medical Association, I was there when he gave that, about the things that he wanted to accomplish. Those were things that I think the president really believed he could accomplish, and then ultimately decided to do it in not a bipartisan way, which is way most of the large legislation in this history of this country has been done bipartisan. If you're going to change a significant part of the economy of the country, the philosophy, the whole viewpoint of the country, you need to have a bipartisan approach, and I think that's where it went off the rails.
So now it's 2016, we've had the Affordable Care Act now for 6 years. Could you talk a little bit about how, in your view, the law has been implemented? Obviously, there's been quite a big change over the last several years. And I'm sure we'll get to this, but you've been, of course, a very outspoken opponent of the legislation. And so maybe we could focus on some of the bigger ticket failures, I'm sure, as you would describe, what those are.
And I know you had Sylvia Burwell here, the current Secretary of Health and Human Services. I'm a big fan of her. She's worked very hard to try to accomplish some of the set out goals. But I think one of the big problems with this legislation, or with any legislation, and people in this school many are going to go into careers of trying to help in public service, and I would encourage you to do that. And to try to see how many people you can help without hurting other people. I mean, that's kind of the whole issue to me, when we can get into that a little bit, is that to help people that didn't have insurance, you shouldn't have had to harm so many people that already had insurance. And that is one of the big flaws of this healthcare law. To the point of how the whole thing has been implemented over the number of years. So the law is about 2,700 pages long. And if you work your way through it, 1,800 times it says the Secretary of Health and Human Services either will or shall will come up with the rules and regulations of that part of the law, because there's a law that's passed, but it doesn't have everything flushed out in there. So the administration kind of gets to then interpret what a law means, and that's where I think things really went off the rails. When the then secretary, not Secretary Burwell, but before that was Kathleen Sebelius, who at the time the president chose her, President Obama got elected, chose her to be Secretary of Health and Human Service, was a lobbyist for the trial lawyers. So you take a lobbyist for the trial lawyers and put him in charge of Health and Human Services to then write the 1,800 rules and regulations. And you say, well, maybe if you had some physicians or healthcare providers in there, it may have done differently. But as I read the rules and regulations, and now you have about 40,000 pages of rules and regulations, that it's a fascinating thing of how government kind of gets too big and out of control and thinks that they have ideas that will work everywhere. And being from Wyoming and in the Wyoming legislature, which I served for 5 years before getting elected to the U.S. Senate, we know that when Washington comes up with a one-size approach for something, for everybody, it usually doesn't work for Wyoming.
So one thing, just to follow up on that, Secretary Sebelius was also a governor. She was a former governor of Kansas. And traditionally, we've had many HHS secretaries who had been governors in their maybe prior political lives. Do you think that there was any state flexibility not? I mean, that obviously was a big part of her career, and if it wasn't, do you think it will change in the future?
Yeah, well, I think that the state flexibility is going to come with Donald Trump in the White House and the things that they've been talking about in terms of a repeal and then a replacement. of the healthcare law. You're going to see it with Medicaid, because the new member of the CMS administrator to take over for Medicare and Medicaid is someone who helped Mike Pence, when he was governor of Indiana, do a number of things with Medicaid, and they could have gone a lot further, but they couldn't have gotten the waivers from Washington, because it kind of comes down to the rules are written, and then if you don't like them, you have to come and say, "Mother, may I?" to the federal government, "Can we do it our way?" And Mike Pence, as governor, said, "Hey, we have a lot of things that will work pretty well in Indiana." In Wyoming, there was a big discussion if we should expand Medicaid. Decided not to, because the program that came up with was one that basically Washington said, "Nope, we're not going to give you that kind of flexibility." So I expect that there are a lot of more ways that we can work to help empower patients. I mean, that's what this is all about. It's empowering patients to help them get affordable care. And the president continues to use the word coverage. And as a doctor, I use the word care. And there's a big difference. And he and I have debated this and argued over time. And he said, well, people have coverage. Well, if you're on a program where it's hard to get a doctor, and the New York Times has written a number of articles about people that have Obamacare but can't get care because the narrow networks and we can go through all the flaws of the problem. As a doctor, I think, how do we actually help people get care? How do we drive down the cost of care rather than give people empty coverage, which is what I think this law has done, empty but expensive coverage.
Well, so on that note, the Affordable Care Act, we know that roughly, according to Obama administration estimates, there have been more than 20 million people now who have health coverage that did not have it prior to the passage of the law. Some of your colleagues in the Republican Party have said, well, they don't, when we talk about repeal and replace, those people, they don't really value their coverage, they don't care if it goes away because they don't think it's good for them. Do you think that's true? Is that true for all of them?
Well, for all of them. Let's just say the Gallup poll last week said 80%, 8 out of 10 Americans say they should either either repeal the whole thing or have significant changes in the healthcare law. So that's 4 out of 5 Americans. And the numbers that you have come up with, you said, 20 million, it's 20 million out of over 300 million Americans. So there are a lot of people that either have not been affected or have been affected in an adverse way. And some of those 20 million, it's interesting, one of my friends and colleagues said he's counted in that because he had actually insurance before that worked for him. But when Kathleen Sebelius came out with her list of the so-called essential health benefits, things that your insurance had to have, had to include. Otherwise, I think the president described it as junk insurance. And I've had farmers and ranchers in Wyoming who've called. So we had 5,000 people in Wyoming who had insurance. They said it worked for them, but it didn't meet what the president said they needed. So, in a state like Wyoming, and states all around, certainly the Rocky Mountain West, when you say, gee, I had something that worked for me, and I could afford it, and it worked for myself, it worked for me and my family, who's the president to say it's not good enough for me? Who is he? Why is government coming into my house and saying, and then they lost their insurance because it wasn't allowed to be sold anymore. And then they had to buy something that met the president's description of good insurance, which was more expensive. And for a number of them, it really didn't cover the kind of things that they wanted covered. So, the approach is, for more freedom, which is my approach, for more government, which is, the president's approach. And it's a philosophical debate, discussion, and disagreement. And I think, this year on Election Day, the American public, this was a big issue in the campaign. It was a presidential issue. It was certainly an issue in all the Senate races. And in spite of a field in the Senate races where we had so many Republican senators at risk compared to the Democrats, we maintained the Senate, and Donald Trump was elected president of the United States.
Also, on that note, from a high level, since we're talking about the Obama legacy here, when it comes to the ACA, it was really about trying to provide health insurance to a relatively small segment of the U.S. population, but still millions of people that couldn't get it through their jobs or through entitlements like Medicare and Medicaid. Of course, we can debate all day as to whether the flaws or the things that maybe were good or things that aren't so good. But now, we're going into 2017 with new congressional majorities and a Republican president. What do you think, could you just describe the future of the ACA? Like, what's your thinking? And 8 years from now, what will the Republicans' legacy be on this issue?
Yeah, well, there are a couple of points when you said they did all this for a small portion of the population. Whenever, if any of you get into policy activities, you go to the Hill or work or get run for office or do anything, if you're trying to deal with a small portion of the population, as you just described, you know, you have to go to everybody and change a system that for many people was working okay to the impact that few. And you can argue whether you needed to or not. But I think that is a big issue because lots of people that had what they liked, and it was a little more expensive. Now it's even more expensive, and it's not necessarily what they like, which is, I think, why even to today, the healthcare law, more people have have a negative view of it than have a positive view of it because of how it affected them personally. I mean, all politics is personal. What does it mean to me? What does it mean to my family? How are those impacts? So if there was a mistake that the Democrats made, it was by doing it not in a bipartisan way, by saying we have the votes, we're going to slam it through, and we know better than everybody else. And I think it's important that 8 years from now, we actually try to accomplish those goals of having more affordable, so people can get the care that they need, not coverage, but the care that they need from a doctor they choose at lower costs. And that's where I would like to see this 8 years from now, and I think that the way you can do that requires bipartisan input. It requires bipartisan involvement, not as some Democrats have signaled that they're going to, fight it tooth and nail and they're going to just stand there and forcefully defend Obamacare at a time when the American people want to move away from it.
Well, so why don't we talk about, obviously it's been stated several times since the election that repealing the ACA is very, if not the number one thing on the agenda for early next year, it's certainly one of the top things. Could you talk about what should be, what's going to be the first step in that process?
People need relief. They need relief from the anxiety, the cost, the worries that they have related to the health care law. There is a mandate. I mean, the Supreme Court ruled that it was legal. I disagree with the Supreme Court and their rulings, but they've ruled that they can force everybody in the country to have to buy a government-approved product. It's the first time in the history of the United States anything like that has ever occurred. So it's very unusual. And the first step is actually to get rid of the mandate. The mandate on individuals that you must buy or be penalized or pay a fine, and the mandate that businesses must supply. And I think lots of businesses do want to supply health care because they want healthy employees. It's a good idea to have people that have insurance that works for them. So that's all part of the process. But there is a process called reconciliation that we passed last time. President Obama vetoed it, but it would have been repealing significant parts of the mandates related to the law and the 20 or so taxes that have driven up the cost of care.
So, if I understand what you're saying, initial repeal, but maybe there will be some amount of time before you develop a replace approach that you think should be bipartisan. How do you keep insurers in the market during that period? Because there are fears that, if there's a process that gets started and we don't know what the outcome is or really what the end game is, why wouldn't they just leave?
We want a smooth transition for anybody people's lives have been significantly disrupted by this healthcare law, significantly. And in terms of they've lost their doctor, they can't continue the same doctor they've gone to. The president says shop around, change insurance policies every year, which means a pretty good chance you may have to change your doctor every year or the hospitals you go to. I mean, people's lives have been significantly disrupted, and we're trying to find a smooth path so there's less disruption, because it took them 6 years to get the cart this far into the ditch. It's going to take some time to pull it out of the ditch, which is why we're talking about a transition period, several years, so that people say, okay, I have time, whether they're on Medicare or Medicaid, or Medicaid with the expansion, whether they have insurance that they bought through the Obamacare exchange, because the people that, the numbers that you've come up with, the 20 million, the majority of those are on Medicaid. The majority of the people are on Medicaid, which is a system that, and it's an interesting thing how that works. There was a story You may remember Jonathan Gruber, the guy that said we got it
How
passed.
could anyone really forget?
Yeah, so we got this passed by relying, as he said, relying on the stupidity of the American people. I mean, he talked about basically duping the American people and the legislators into supporting the health care law, and that's why it's there. He had a story recently that said that with the Medicaid expansion, which signed up some people, his report is that a majority of these about 11 million people that are now on Medicaid, as you say, the low-income people, actually qualified for Medicaid before the health care law was passed. They just hadn't signed up. And I mean, I saw that as a doctor. Patients I've taken care of over the years, and see, you should qualify for Medicaid. And then they go sign up. So even the expansion of Medicaid helped increase coverage for some.
Right.
But there were many people that were eligible beforehand and just hadn't kind of filled out the paperwork.
One of the things you've talked about getting rid of the individual mandate. Obviously, this is one of the most, if not the most, most unpopular piece of the ACA. But what on the other side of that, what President Obama and other Democrats have said is that you need something like that to make all of these great things about the ACA that are quite popular. Pre-existing condition protection, letting young people stay on their parents' plans until they're 26, no annual or lifetime limits on coverage. To have all of those great things, you need something unpopular like the mandate. So how do you think about that differently?
Well, that was litigated in the election this year. It was litigated in Pennsylvania and in Ohio and in Wisconsin, where Republican senators who were supposed to lose according to early polling all won. You can kind of run because they spoke out against what you just said. You have to give up all these freedoms for all these great things that the president wants to do for you. And a lot of people didn't like that idea. So, I mean, that's what democracy is all about. Now, with the way that the reconciliation bill was passed last year and put on the president's desk that he vetoed, and the one that we're crafting this year, people under the age of 26 can still stay on their parents' plan. That is not taken away. And 6 or so years ago, we had the round table at the White House. I was interviewed beforehand during the lunch break, and they said, well, what about the people up to age 26? I said, you could pass that today. You'd get probably almost 90% of the Senate would vote for it. You could pass it today without having to kind of reorganize all of healthcare in America. And even components of the healthcare law that I thought that I liked that had to do with accountable care organizations, the concept, it's like 6 or 7 pages in the bill. And then the Secretary of Health and Human Services came out with over 400 pages of regulations, 27 pages of legal guidance. This gets down to how regulations are written, to the point that the president stood up and said, the best places that are doing this right now, the Mayo Clinic, Geisinger Hospital in Pennsylvania, the Utah healthcare system, when the list of 64 things that a hospital had to do to become an accountable care organization came out, they all said, I can't do all of that. So even the places that the president had highlighted, and I agree, did it right, and I agreed with those pages of the bill, even they said, my gosh, these regulations, we can't comply. So if you want legislation to work for the betterment of all people, you want to come up with something that doesn't hurt individuals, and that it works, that actually is a path to success, rather than that the most successful participants say, well, we can't make it.
Mm-hmm. Well, actually, so you stole one of the questions I was going to have were, are there elements of the ACA where there is or should be, do you think, broad consensus that this thing has actually worked? I know there's obviously a lot that you think that hasn't worked, but are there places where you can find agreement?
Well, I think it's a good idea to have young people age 26 to be able to stay on their parents' plan. I'm supporting that, and we could have done that without the whole law. I mean, that was kind of one of the sweeteners that was put in to get people to vote for it. But there were so many things that people found out to be unpopular that when the voters came to vote, whether they voted in 2010, and Nancy Pelosi was no longer the Speaker of the House after she had said, first you have to pass it before you get to find out what's in it. And then President Obama was reelected, in 2012, but then in 2014, Republicans took the Senate as well, and now the presidency this year. I mean, these were all votes on the president's vision, as well as the way that the so-called Affordable Care Act was implemented. And that what I'm telling you, the 40,000 pages of regulations had a lot to do to make it in ways that it did not work for families all around the country. And I want things to work for families. I mean, as a doctor, that's what I want to make sure that families get what they need.
So, just from a macro kind of level perspective, when people talk about the ACA, a big part of that debate over the last several years, as you suggested, has been about access, broadening the number of people who have health insurance in this country. The second side of that, of course, is cost and what people pay for their coverage and how much it affects their pocketbooks and versus all the other things that you need to pay for. So health care costs, health insurance, I should say, reflects the underlying cost of medical services, new technology, costs for things like prescription drugs. How do we address that? Should more have been done over the last 8 years on that particular issue? And if so, what should have been done differently?
I agree with you. I think you need more competition rather than less. But right now, was it a quarter of the counties in the country? There's only one insurer selling on the exchange. Mm-hmm. Insurance companies are dropping out in a lot of things because most people think that what they have to buy, this insurance policy that the president says they need, even though that's not what they say they need, is so expensive that they say it's not a good value for my money, even with the subsidies. I mean, the idea was, as you said, everybody had to buy, and then the money that went in would help subsidize those that didn't have it. So many people said, wait a second, I'm not getting a subsidy, which means I must be paying somebody else's subsidy. So what I want to do is give more freedom, flexibility, and choice at the state levels. I've introduced legislation over the years to do that from the beginning, to let states make decisions about whether the individual mandate needed to go or not. We've always pushed it. If New York likes what they have, California likes what they have, let them keep what they have, as we went through this whole debate over the last number of years. But what about, Wyoming? What about other states? If it doesn't work for them, why must they live under this same thing? And if the insurance commissioner in a given state says, yeah, this insurance is okay to be sold in our state, why is that not good enough for Washington? I mean, it really comes down to a decision of, do you see Washington having all the answers, or do you see better decisions being made at the state level and by individuals? And I just have, having been in the Wyoming legislature, I just have much more confidence that people in that legislature have kind of their ear to the voice of the people that live in that state and know what works in that state much better than, and I think Medicaid is one of the prime areas where you can do a lot to help provide less expensive and more effective care.
Well, so can we have a system where you take away, let's say, some of Washington's regulations, the way that they set minimums for what has to be covered, and you make states already are primary regulators of insurance in a lot of areas. Can you have that, but then still provide the same kinds of protections on access, ability to get coverage at relatively affordable premiums? Let's say if you're quite sick, people who have cancer, people who have very expensive medical conditions, who, as I'm sure you know, of course, before 2008, you would just hear these stories about just people going into bankruptcy because they couldn't get the care that they needed. So I'm just wondering, how do you see that working out, and do you think that even if the balance is different in terms of where the regulations are coming from, can you still provide that protection to people?
Well, and the way you do it, there are ways to do it, and we discussed this at that White House roundtable. The president didn't like what I had to say, but it was that I think you have to have some level of catastrophic coverage, so that nobody goes bankrupt, loses the house, or the student has to quit college because of it. And what I think you also need to do is have a system like what they call a health savings account, where people actually are kind of shopping around with that money and saying, and that, I think that helps drive down the costs, because people are actually making calls and say, what does it cost to get an x-ray, what does it cost to get an MRI, and it's like their money that they're spending, as opposed to the fact that they just don't think about it that way. So, I mean, that's a way to help give people the opportunity to take more responsibility for their care. And so that helps with the bankruptcy code. My wife's a breast cancer survivor. I mean, she's had surgery 3 times, chemotherapy twice. So as a doctor and a husband, I know that it's important for people with pre-existing conditions to be able to continue with their care and not lose their coverage. The way the law is written right now, and I don't know if you've seen this, in Pennsylvania there have been over 250 people who, once they got sick, signed up, have generated bills of over $100,000, got their care, and then dropped their insurance. Well, that's a complete, I don't think the president designed the system that way, but that's how they wrote the regulations. That come in when you want, get out when you want. And I think it's important for somebody, if they're insured, to not be able to have that insurance lost or premiums way raised because they've gotten ill. So I think you shouldn't be able to drop people who have a condition if they have continuous insurance. But folks that just kind of come and game the system and go on and off, the American people, because as you started by saying, well, we heard stories about this. We're also hearing other stories about other things that the American people don't like either.
Right. So how do you prevent that from happening? Right. I mean, we've seen one of the issues with the ACA is, right, people will come in, get their care, and then they will drop their coverage. Maybe they decide that paying the penalty, the individual mandate penalty, is more worth it at that point. How do you prevent that sort of from happening?
Well, I think the regulations are written in such a way that it's pretty easy to do. You can use a hardship clause and pretty well say, well, I couldn't do it.
Yeah.
And that's why we just want to eliminate the entire individual mandate. I mean, you made the case earlier that if you don't have the mandate that makes everybody here buy it, then there's not the money available for some other things. And what I'm saying is, you know what? People aren't buying it anyway. Even they'd rather pay the penalty than because they look at it in terms of is it a good deal for them or not. And so many people think it's not a good deal for them, which is why it's been unpopular, why 80% of the people last week said we need to either repeal or significantly change.
So before I turn it over to the audience, because I'm sure we have a lot of questions from our students here, I wanted to just ask just a broader political question. Healthcare obviously has been an especially partisan issue over the last 8 years. Is it destined to be the same for the future?
Well, I'd like it not to be the same. I'd like to actually work with people on both sides of the aisle. The biggest pieces of legislation that have been successful, whether it's a civil rights law, whether it's putting Medicare into place, was done in a bipartisan way. And you look for good ideas from both sides. Neither party has the monopoly of good ideas. So I think you need to talk to people on both sides of the aisle, work together. We do actually pass a lot of things in a bipartisan way. They don't get much press because it doesn't seem to be that sexy. We did a thing with on education reform. We're going to do a major water resources bill. We're working on an energy bill. I mean, you kind of look at some of the things that we've been able to pass, but it doesn't get much news or most attention. It's the best way to do legislation. And there are kind of 2 ways to look at major pieces of legislation. One is because there's a lot of stuff out there, and I think most people can agree on about 80% of the stuff. And if you just leave the other 20% out, you can get a lot done. But if you just want to fight about the 20%, you don't get anything done. So it's better to focus on the stuff that you agree with and just kind of go a step by step in the right direction. But there are huge challenges facing the country. We have a growing older population, and we can talk a little bit about that if that comes up in the questions. But that's that whole, the Medicare component of that, where they set the age at 65 for Medicare at a time when not too many people were living past the age of 65. They did the same thing with Social Security. So now we're looking at those kind of tidal waves of Social Security and Medicare in terms of funding the country and the current debt that we have to deal with too.
All right, so I'll turn it over, I guess, to the audience. And so who wants to? Oh, we've got a lot of questions here. Should I just pass the mic around, I guess? Do you want to? Oh, sure. Yeah, why don't we do that? Sure. Why don't we start right here?
Hi, Senator. I want to thank you very much for coming. So I've been following the repeal of the ACA pretty closely, and I've read that to repeal it, it would take anywhere from 6 months to 3 years, I think, on Politico. And so my question is, as a Senate Republican, what time frame do you think the ACA will be repealed by?
Yeah. You know, if we can use that process we used before, we get that onto the president-elect's desk once he gets into the White House. And that can be done pretty quickly, probably in January, beginning of February, as an early part, which is to get rid of the mandates immediately, try to provide relief for people, but at the same time provide the reassurance that people aren't going to lose what they have as we work on putting up a full replacement model. But you know, people age 26 will be able to continue on there. But we're looking at ways to make sure that people actually get the care they need from a doctor they choose at lower cost, which is what you don't have now.
Senator Barrasso, thank you very much for coming in to speak with us today. I'd like to begin my remarks by saying I'm a huge supporter of yours from the state of Massachusetts, and I thank you for your service. In 2010, there was a special election in my state where Scott Brown defeated Ted Kennedy, or Ted Kennedy's seat, which he called the People's seat. And I was just wondering if you could go into greater detail about your role in the ACA negotiations and also the impact that Scott Brown's election had sort of on those discussions as well. Thank you.
Yeah, when Scott Brown beat Martha Coakley, that was in January of that year, and the Christmas Eve vote, about 3 weeks earlier, was the vote where the Democrats had 60 votes, which is what you need to overcome cloture. And the bill was written behind closed doors in Harry Reid's office, and I mean, we go through all the details of that, but there were certain senators that weren't willing to vote for it, Democrats, because they had to get all 60 because the president couldn't convince any of the Republicans, because we looked at the thing and said, wait a second, we read this, it's not that good. So they went to Mary Landrieu, the Louisiana senator who was one, Bill Nelson from Florida, and then Ben Nelson from Nebraska, and said, well, if you vote for it, what do you want? I mean, this was kind of like watching the old movie Team of Rivals, and Lincoln was working on you need a bridge? Okay, you're going to vote for my bill. So they came out with a special deal for Florida, and we nicknamed it Gatorade. And then Bill Nelson was on. And then Ben Nelson said, hey, what about Nebraska? We don't want to have to help with paying for Medicaid. Because, you know, up until then, Medicaid, states contributed about half, depending on the state, and the federal government put up state. So when a state was going to expand Medicaid, it cost the state too. So they said, okay, and we'll make sure that Nebraska doesn't have to pay for any of the Medicaid for the first 3 years. We called it the Cornhusker Kickback. And Ben Nelson was in, but other states said, well, wait a second, if you're going to do it for Nebraska, why not for us? Which then President Obama said, okay, we'll do it for everybody. But that's how you went from the Medicaid expansion to say, just increase the age of eligibility for working men, to say, and it was going to be federal paid. And then Mary Landrieu had some things that she wanted in Louisiana, which then President Obama agreed to, and we called that the Louisiana Purchase. And they got their 60 votes. And it passed on Christmas Eve of that year. And people all around the country were enraged. Hated it. Because first you had to pass it before you got to find out what was in it. And there were a number of Republicans that were saying, well, look what's in it. Look at this. Look at that. And that's how, with the special election for Ted Kennedy's seat in Massachusetts, Scott Brown won because the Democrats had 60, and he was going to block the 60 for when we came back after Christmas to formally pass the whole thing into law. And for the people of Massachusetts to reject Martha Coakley and elect Scott Brown, a Republican, to the United States Senate should have sent a signal to the President and the Democrats that they were heading down the wrong path. Because if in your home state, they chose to elect a Republican to the Senate, which they did, and the only issue was Obamacare, and Scott being to break the 60 to get it to 59, that should have been the message that would have said, let's take a step back and do this in a bipartisan way. But they didn't, which is why then they had to do this reconciliation process, because they never had 60 votes again.
I'll echo the same statements. Thank you very much for coming today, Senator. My question...
Never stand between the camera and the host.
I was hoping you wouldn't mind expanding a little bit upon the current discussions and what a Republican-controlled government, what kind of health care bill would be coming out in the next few years.
And again, I would like to see something done in a bipartisan way. I mean, we have a number of ideas. We know what hasn't worked. We want to find ways to work, both sides of the aisle, but do a thing that actually lets people have much more control. And I'm willing to work with anybody on either side of the aisle, as long as it's aimed more toward freedom, more for freedom, less on government. I'm for small rather than big. Whenever government tries to do big things, it doesn't do it really well for the most part. So, individual freedom, individual choice, and work along those lines. So, and I think we're going to have some receptive Democrats doing that, because come the next election, one is it's the right thing to do, but also when you take a look at the 2018 Senate landscape, there are only 8 Republican senators who are up, and there are 25 Democrat senators who are up. And of the 25 that are up, 10 of them are in states that Donald Trump won. And health care has been a major part of the discussions in those states. So I think it's incumbent on everybody to work together to solve the problem of trying to lower the cost of care and give people more freedom. And to me, that's more free market principles and fewer government. I think, you have more competition, it's better. But what we've seen with this law, as the law was written and then the regulations came out, which made it even worse, that we found that it's eliminated competition and driven up prices.
Senator, thank you again for being with us. So my father's an insurance broker, and I think perhaps similar to you as a doctor, kind of has that firsthand brush with the effects of what the law has had. He talks to me a lot about the premiums that he sees increasing, providers that are exiting states, so on and so forth. But in talking to him in advance of your visit today, competition, I think, has been the primary issue for him. He's one of the harshest critics of the law, but he looks at the damage that's done with providers leaving. So for folks like him, what would you say in terms of are the critical steps that need to be taken and as Republicans move forward with the alternative to say, here's how we're going to get providers that are back into these states, because he's seen it across the board. And then I think the second part being pre-existing conditions as something that there seems to be an emerging consensus around the catastrophic coverage that you talked about. Are state-based high-risk pools the way to go there, or do you see an alternative there?
Yeah, we had a state-based high-risk pool in Wyoming for people that have had pre-existing conditions. The current law only allows the sickest person to pay 3 times what the cost would be to a young, healthy person that goes to the gym every day. And that's not truly reflective of it, because to stay solvent, as your father would say, they'd have to charge that young, healthy person much too much, which is why the young, healthy, even in spite of the mandate, aren't buying. Even with the subsidies, aren't buying. So, I think from a standpoint, from your father's standpoint, and John McCain and I had a town hall meeting in Arizona with a number of folks that seem to fit your father's description in terms of what they do for a living. If they can come up with a product that people want to buy, they should be able to sell that. And it should be based on working with the state we've talked to this group in Arizona, wherever your father's from, rather than saying, and Washington's going to tell you what you have to sell. I mean, that's the issue. So, and state high-risk pools work in Wyoming. We obviously did subsidies for those people because the true cost of the insurance for them would have been too high. But they pay more than somebody that's going to the gym, every day and is very healthy. commensurate somewhat with a risk, but with a significant subsidy from the state to help with that high-risk pool. And that's a program that works. Yes, ma'am.
Hi, I was wondering if you can give your comments on your thoughts of Trump nominating Tom Price for Health and Human Services.
The Tom Price and I have known each other for 20 years. I think he's an excellent selection. He's an orthopedic surgeon. He was in the Georgia state legislature, so he knows what it's like as a legislator. He knows what it's like as a doctor, as an orthopedic surgeon who's taking care of families, and he knows what it's like as a member of Congress who's been there dealing with the health care law. So I think it's nice to have somebody that has all of those experiences. And overseeing Health and Human Services, to have that knowledge, and especially with the issues of Medicaid and some of the things that they did in Indiana, it's his knowledge base that I think is really good and going to be very helpful. He has probably spent more time thinking about healthcare and healthcare law. He has an alternative bill that he's introduced, and you can debate it whether you like it or not, but it's a much more free market, consumer-driven than a government-driven process. And Tom, I think just is the right person for that job.
So, you just talked about the reconciliation process and how the Obama administration used that to get healthcare legislation passed. I was just reading an article that kind of stuck to my mind. Scott Walker is advocating getting rid of the legislative filibuster as well. So I wonder if you agree with that process, and how will it work if Republicans pass legislation by a simple majority in the Senate?
Yeah, the question was about the filibuster, and I always thought the filibuster had a very important role, and does have a very important role, in the way that the Senate operates. The House is really built for offense. You got one more vote than the other side, you can do anything you want pretty quickly. And the Senate was built in a way to say, let's kind of cool things off. Let's not go too fast in any direction. That's why you have 6-year terms. It's why only a third of the members of the Senate are elected every 2 years. So it is supposed to be more of a deliberative body. But then what you saw a couple of years ago was that Harry Reid, as the majority leader, decided to do away with the filibuster with regard to nominations. The idea of 60 members of the Senate for approving nominations or legislation is so things don't go too far one way or the other. And you would want people nominated to serve in a cabinet, serve as sub-cabinet positions, who can attract votes from both sides of the aisle. I mean, that's kind of the idea, is have somebody that's not such a firebrand one way or the other. And now there was, I think, a story in one of the major newspapers this week about the fact that since they've gotten rid of the filibuster they've done it on nominees for courts, for cabinet positions, and for sub-cabinet positions, it's going to be a lot easier right now for Donald Trump to have the people that he has nominated to the cabinet to get confirmed, because the filibuster doesn't apply to them. So it's kind of whatever one side does, as time passes, it can kind of come back the other way. Now then you asked the specific question about legislation, and I would much rather work for legislation that I think is going to work. And it works when you get, I think, a good number of people buying into that legislation. So when we did the rewrite of No Child Left Behind, I think it passed 93-6. Left the bad stuff out, focused on the 80% of the things that people agreed on. I think that's important. We did the same thing with this water development bill that's come through the committee that I'll be chairing next time. That it was an 87-12. The energy bill that came out of the Senate, 83-15. And people disagree on energy, disagree on water projects, disagree on a number of things, but let's get to the point of things that we agree on. So I much prefer a bill that's not on party lines. And I think if you go and get rid of the filibuster, two things. One is, you don't always get everybody in your own party on something. to vote for it. So if you have 51 members and you need 51, everybody's not necessarily going to agree. But I think much more important is you ought to focus on the 80% of the things that people agree on and get these things done in a good bipartisan way.
Later today, you're going to have a vote on the 21st Century Cures Act, which passed in the House with a strong bipartisan vote. What is your take on that, Senator?
With all legislation, you say, is it constitutional? Is it a good idea? Can we afford it? And I think it's constitutional and a very good idea. And I think we can afford it, but there's some debates about what you can afford to do. I like the idea of a number of the things. This is something that's going to be bipartisan, I believe. I know Elizabeth Warren has come out pretty strongly against it, but I think it's important for people to have an opportunity to get the best. I know that Joe Biden has come out in support of it because of the issue of the cancer moonshot. Lamar Alexander, chairman of the Health Committee, is focused very much on it, and the vote's at 5:30 this afternoon. There was so much legislation. There are a lot of good ideas out there, and you got to say, what can we afford when we have a debt of $20 trillion, approaching that right now. And I'll just kind of the bigger question as we look to the 21st century cures, but also moonshots and also just big ideas. So my mom's in her 90s. When she turned 90, went to a little store in Cheyenne that Franny is very familiar with, and they had a little card about people born the year she was born. Who was the president, what kind of music they were listening to, what was the cars they were driving, life expectancy. So they said we have an older, graying population of patients. The year my mom was born, life expectancy in the United States for women was 56. And she's still alive. So now the life expectancy for women is 81. So through all of the wonderful things we've done with education, with clean water, clean air, health, better medications, better medicine, we have added 25 years to life expectancy in this country in my mom's lifetime. The last time we added 25 years to life expectancy in this country, and not in the country but in the world, was in the time of the cavemen. Life expectancy for the cavemen was 31. The year my mom was born, it was 56. Now it's 81. So we have this group of people who, when they put Social Security in play, at the age of 65, people really weren't living to 65. And then when they put Medicare into place, Lyndon Johnson, The Great Society, you read some of the original stories, it was for the widows, because the guys were all going to be gone, but for the widows to have their health care taken care of when their husbands were gone. I mean, it was a very different time, different country, if you will, but we're still living under those rules at the age of 65. So the number of people growing older, I mean, 10,000 people a day, are turning 65, going on to Social Security, going on to Medicare. And we have not come to a successful conclusion on how to make sure that the math works out, just in terms of the number of people retired, the number of people working, and how to continue to provide health care, services, all of the things that this population and this society needs. And those, to me, are the big challenges. And as we do more and more with it, it made me think of it, Scott, because you mentioned the 21st century cures. It's to help those people live longer, fuller lives. But as we continue, that means more and more people over the age of 65 being helped along by others under the age of 65. And how do we as a nation, as a society, continue to do it? And that, to me, is going to be one of the largest challenges that we're all going to have to grapple with as some of you then pursue careers in government, politics, and trying to help other people. Doctor?
I was an older fellow that asked the question, so I felt okay. Two things. One is, I'm interested in veterans' health. I just want to point out that the VA actually takes care of less than 20% of veterans' health care, and that I think and not at all about families. And I think we ought to be thinking a little bit about veterans' health care and the general healthcare system. Second question is, there are some trends that are happening partly because of the Affordable Care Act, but also for other reasons, such as bigness, large practices, hospitals buying up physicians' practices, practices becoming larger and larger. And you look at some places, there's maybe a few practices left. Do you see that continuing, and do you encourage that, or is that something in the future?
Yeah, we'll get to veterans second, and the issue of bigness and hospitals buying hospitals, and in Boston you've seen that consolidation. In New Haven you've seen Yale take on a number of other hospitals. One of the architects of Obamacare wrote an editorial in the New York Times who was one of the proposers of that, and said, I was wrong. That's what he said. He said, because we thought innovation by having all of this root thing would help. He said it doesn't. They're all kind of stovepiped, and in ways that innovation happens much better at the local level, and we should not have done this way. So what they found is it often has just created monopolies, which is why prices have gone up faster in some places, and I think Boston's one of those places. So no, I don't encourage it. I'd like to see diversification and decisions at that level. The VA hospital is interesting because as you're so involved with that in your career, I worked at the VA here as part of my medical school days at Georgetown, at the VA in DC. I was at the VA hospital in New Haven, or in West Haven, Connecticut, when I did my orthopedic residency at Yale. And we have 2 VA hospitals in Wyoming, one in Sheridan and one in Cheyenne. And as you said, it's only 20%. That's because we have veterans living all over the state of Wyoming, but you can find yourself easily 300 miles from a veterans hospital in a lot of rural places, which is why the Veterans Choice Act has come about, and trying to work the ways through all of that. And I spent a lot of time with our veterans. I spent Thanksgiving in Afghanistan, in northern Afghanistan with the Wyoming Army National Guard. Been to the Gulf twice this year. I always go to see our troops. In the summer, the day I was there in the summer was 108 degrees, which was the coolest day that they've had in a long time. So you want to go to thank them, to make sure they have what they want, make sure that when they get home they have friends who are willing and able to help in every way that you can, because we owe them a great deal of great debt. And not just them, to their families as well. War is very different now than it was, kind of as you were in Vietnam era, and when people went, they went, they looked for mail call. Now they're, closer to home in many ways with Skype and on cell phones. But that adds different challenges. And the other is, if you talk to, how war is fought, World War II, Korea, when they went to war, they stayed until it was over. And you talk to Stan McChrystal, who was the 4-star, was in charge of Afghanistan for a while. He says when he meets with people in the field, they say, what would you do differently if you knew you couldn't leave until the war was over? And they say, well, we do this and this and this and this and this. So it is interesting because you see people with so many deployments, and I was with a group of veterans, a group of soldiers in Afghanistan having Thanksgiving dinner, and 4 of them I had had Thanksgiving dinner with a couple of years ago when they were on a deployment to Iraq, and I was with them in Kuwait, in and out. So they are incredible individuals, and we owe each one of them a debt of gratitude, and not just while they're serving, but for the rest of their lives. So thanks for what you're doing for our veterans. Yes, ma'am, you have a question in the back?
I think we're actually all out of time. So that's, unless.
Do we have time for a quick one, Kayla?
We can do it real quick.
Lightning round, Senator. Are you capable of doing that?
Yeah, sure.
All right, here we go.
Yes, hi. I understand you object to the mandate, but can you tell me as a physician what your feelings are about the non-essential preventative health benefits that are part of these health plans?
Yeah, the question was about the essential benefits or the non-essential preventative.
The preventative,
Yeah.
yearly physical.
Yes. Yeah, the interesting thing, because my wife's a breast cancer survivor, the idea that they would be included. The fascinating thing again gets to the regulations. A mammogram is only considered a screening test if they don't see anything. If they see something, then it was diagnostic, and then you have to pay. This has been a big issue on colonoscopies. Sorry, we're colonoscopies here. Because they say, we'll pay for a screening colonoscopy. So they do it, you go through the test, the whole deal, you go through prep ahead of time and look up there. If they see something, he approaches, you want a biopsy to see is it cancerous or not. It's no longer now a screening colonoscopy. Now it's become a diagnostic and therapeutic colonoscopy. So you go under, because a lot of these are done with some like sedation, thinking you're going to get something covered, and then you leave with a bill for over $1,000 because they saw a polyp, and then you get another bill from the pathologist. And you have Obamacare, and you have a $6,000 deductible, $12,000 for some families, and now you've had your, quote, free colonoscopy, and you got a bill for $2,000 for it. But that's how the regulations were written. So, again, I've been so critical of the law itself, the fact that it gave bureaucrats 1,800 opportunities to come up with regulations, and they've come up with them in ways that just don't make sense, which is the 40,000 pages of regulations, and which is why I know you had Sylvia Burwell here, who I actually think has tried to correct so much of what has been done poorly by the first Secretary of Health and Human Services.
And I think that's all the time that we have. Senator, thank you so much for doing that.